escalation to be between 25 and 100%. So basically 25 to 50% for mild to moderate pain, 50 to 100% for moderate to severe pain, but not increasing less than 25% or more than 100%. And that's why a 5 to 15 range, which I do see all the time in charts, but that's not a technically correct answer because that's more than a 100% increase. The nurses will not actually give the 15 generally right away. They will keep the patient safe, but it's just our responsibility as the people writing the orders to write an order that's always going to be safe. In terms of increasing less than 25%, people fall into that trap when, say you're on UW HemOnc and somebody is taking 50 milligrams of morphine at home, and you think, gee, that is so much morphine. I'm just going to give a little bit more. I'm going to give 55 or 60. But really, that's less than 25%, and the patient just won't notice that. It won't help them. And so do a good 25% increase, or do something else like a PCA, or switch to a different opioid, which we'll talk about in a minute. You can increase short-acting oral opioids every couple of hours. Sometimes you don't want to give IV opioids for breakthrough for some reason, and you really want to be titrating somebody up on the oral agents pretty quickly. We don't use long-acting opioids in the hospital very much. We use them if people come in on them or when people are starting to leave, but if somebody is on those, we don't increase them more often than every 24 hours, 72 hours if it's the fentanyl patch. What about those long-acting opioids, the OxyContin, the MS-Contin, the fentanyl patch? While scheduled pain medications are often appropriate for constant severe pain, again, we don't start the long-acting opioids until the pain is relatively well controlled, until we've confirmed that there is a good plan for somebody to get them as an outpatient or to taper down. In the meantime, we can schedule short-acting opioids, oxycodone, scheduled 5 milligrams, Q 4 hours, hold for sedation. So again, my best answer in this scenario is B. All right, poor Mrs. S. She is stuck in the hospital. It's trauma season at Harborview. She could not get her OR slot or something. This is a totally artificial situation, but just to practice switching over between opioids, let's say that she is strictly NPO. Can she have some IV meds? At this point, her pain is finally well controlled on 7.5 of oxycodone every 4 hours, and you decide that your new agent is going to be IV hydromorphone. So I don't have a question in here, but I'm just going to talk a little bit about principles of opioid conversion. So again, switching from one opioid agent to the next, which is another thing that maybe some of you already have had to do. It's something that comes up quite frequently. People need to be switched to all IV. People are having side effects. Their insurance doesn't pay for what they've been on, and you have to switch. So you go into your trusty EMR, you total up the total opioid use in the past 24 hours, and you use an opioid conversion chart or website. I have a screenshot of the one I have on my phone, which is the one with a little, I think that's a morphine molecule. It's free. That's a pretty good one. The key is the concept of incomplete cross tolerance. So if I am taking oxycodone for more than a couple of days, my opioid receptors are used to the oxycodone. Again, if you've had a patient that you've started on opioids in the hospital, you may have noticed that the first day, the first 24 hours is when they have the most side effects. They feel a little bit nauseous, they feel a little bit sleepy, but you've held the course because they have good pain control, and the next day they're not noticing those side effects so much, and they're just getting the pain control. And you don't want to put the patient through that twice. And so when you add up your 24-hour usage, you plug it into your calculator, you come up with a number. You don't go ahead and divide up that number and prescribe it. You decrease it by 30%. And that calculator will actually remind you, a lot of the websites will remind you to do that. And never hesitate to ask for help. These are, while I firmly believe that we can safely use opioids in the hospital for acute pain, it still is a big deal, especially when you're new. And so just never hesitate to ask for help. Any questions? I'm looking at my chat. All right. So again, the concept is equa-analgesic dosing. It's not that hydromorphone or fentanyl, which I don't have on here, but is dosed in micrograms, is inherently more dangerous. It's just more potent. And so you do not have to have this whole chart in your head. You should probably have that IV hydromorphone is and IV fentanyl are the most potent. So if you are converting to those, you should have a smaller number coming out. As a reminder, the first thing I suggested that you try to commit to memory is when you're titrating opioids, you titrate by 25 to 100%. The second thing that you might consider committing to memory is just this one rough conversion, which is 1 milligram of IV morphine is roughly equivalent to 3 milligrams of oral morphine, or 2 milligrams of oral oxycodone, or 0.2 of IV hydromorphone. So again, IV hydromorphone is more potent. And so I'm not going to go through this in detail, but you would add up her 24-hour dose. You would come up with a dose. You would give it every 2 hours, or you might consider a PCA. I did not check to see that my office mate was not coming, so I'm just going to put my mask on. No, sorry. So you have a new admission. This is Mr. G. He is a, oh, she left? Okay, good, sorry. Your new admission is Mr. G. He's a 73-year-old man with metastatic prostate cancer. He is on hormonal therapy. He has some spine mets, and he's admitted with increased pain, somnolence, new renal failure with a creatinine of 3 with from a baseline of 1.0. His medications were, as I have them here, he was on oral morphine. So he has diffuse bony pain that was previously well controlled on 60 milligrams of morphine every 12 hours and some morphine IR for breakthrough. Over the past few days, he is having more pain and he is more somnolent. His vitals are stable. He's somnolent but arousable. So in this case, I'm actually just going to give you my answer that his morphine, especially his long-acting morphine, is building up because of his renal failure. And this is something that you might see, for example, on a hem-onc service if somebody is well controlled on morphine, but then their renal function deteriorates. So this is an opportunity for me to talk about opioids in renal insufficiency. So in renal insufficiency, the optimal agents are methadone and fentanyl. That's actually a bummer, right? Because methadone is a very long-acting agent. Fentanyl is only available in a short-acting IV version and in a long-acting fentanyl patch and in a lollipop that costs $10 and is really for very specialized situations. So, as you've probably seen already with your patients, what we use is hydromorphone, Dilaudid, and oxycodone. And we just use them a little bit cautiously with lower doses and sometimes extended dosing intervals. In dialysis patients, the optimal agent, if you can't give fentanyl, is hydromorphone, because there is a metabolite that builds up if people are on oxycodone. We should avoid long-acting oxycodone, and we should avoid morphine. In liver failure, fentanyl is optimal. Again, we use hydromorphone and oxycodone with caution. And we should again avoid morphine and long-acting oxycodone. I have one, and generally avoid methadone. I have one question which I'm going to hold just for a couple of slides so that I can get to the kind of punchline about liver and renal failure, but that's a great question. So in summary, with renal and hepatic insufficiency, we should avoid both morphine and long-acting oxycodone or OxyContin. We should avoid methadone in liver failure. We should avoid fentanyl in both, or sorry, fentanyl is optimal in both, but we use hydromorphone and oxycodone with caution in both, and hydromorphone preferred in dialysis patients. Any questions about liver and renal insufficiency and opioids before I move into the other question? Okay, so steroids for people with worsening bony pain. Steroids are a really good option for pain related to bony metastases. NSAIDs are a good option. Opioids do help in that situation. Often radiation therapy is really what these folks need. Whether you should give the steroid overnight emergently is a more nuanced question related to other risks that for steroids that patient may have, and their chemotherapy regimen, and where they are in their diagnostic process. So I don't know how to answer that with a blanket answer, but yes, steroids are effective for bony pain. If somebody is near the end of life with comfort-focused goals, I would personally generally give that person some steroids when they hit the door. All right. A few more words on opioid choice. I am not saying don't use morphine. It's a great first-line agent for people whose kidneys and liver are working pretty well. It comes in all the different flavors, solution, pills, sublingual, IV, all of that. It's really cost effective. On some insurance plans, oxycodone is shockingly expensive. I do avoid codeine. It mostly makes people throw up and doesn't really help their pain. I avoid Demerol or meperidine. It has a risk of seizures and delirium. It does have a theoretical benefit over other opioids for rigors, and I think it probably still is used somewhat on the HEMONC service, so I would follow your attending's practice on that. I personally would try another opioid for rigors if I needed to treat rigors. It should not be used in renal failure. And then I don't use tramadol in the acute inpatient setting for pain. It probably has a role in the outpatient setting, but it's not safer in my mind than these other agents, and just isn't very effective. So again, to summarize, Mr. G, his morphine is accumulating in renal failure. What I would do for him, if he wakes up with pain, I would give him a little bit of IV hydromorphone or IV fentanyl. I would give him some oral oxycodone or hydromorphone when he's alert. I might consider a fentanyl PCA, and then I would discharge him on oral scheduled oxycodone or hydromorphone or on a fentanyl patch. In general, a suggested protocol for malignant pain, so a patient like this who has constant malignant pain is an excellent candidate for scheduled long-acting pain medication, long-acting opioids on an ongoing basis at home. If they come in and they haven't been taking a very consistent regimen, this is the protocol that I would follow, and this is going to be in your slides that you can refer to. Starting a short-acting scheduled opioid, Q3 to 6, order something for breakthrough that's about 10% of the 24-hour dose, adjust the scheduled dose every 24 hours based on the PRN use or the symptoms. If we didn't talk about this when I talked about opioid dose escalation, de-escalation is similar. If somebody is too sleepy or even has a little bit of respiratory depression, hold the next dose and then decrease the scheduled dose by 25 to 50%. And then if your team has decided this patient needs to go home on something long-acting, we wait till their pain is controlled to convert. I threw out the idea of a PCA in this scenario, so I'm just going to talk about that briefly. So PCA stands for patient-controlled analgesia. It's a safe method of delivering a relatively constant, really low dose of opioids. It is appropriate for an alert patient. It is appropriate for pain that is severely impacting function. It is appropriate when the appropriate 24-hour dose is unclear, or when somebody is having a lot of pain and you really need to get them under control. It is also particularly helpful when people really need control over the dosing. They need to be able to get up and go to the bathroom, and they can't do that because they're having too much pain. They're having significant distress because they need opioids pretty frequently, and it's really just not possible for the nurse to get there in time. Yes, we can definitely consult the pain service, but there is a safe and relatively straightforward protocol in ORCA. I'm not as familiar with the VA, but I believe they have some kind of primary service PCA. And so with support from your senior resident and or attending, you as the primary team can prescribe a PCA. So here are the elements of the PCA orders. There's a lockout dose, that the little machine that the person has, the little thing that they hold in their hand, when they press that, that's called the incremental dose or the lockout dose. It's usually something like 0.5 to 1 of morphine or like 0.2 of Dilaudid. There's a clinician bolus. The clinician in this case refers to the nurse, and that's when the patient is pressing the button and they still have pain. And then they call the nurse, and the nurse can give a larger dose. She can give, I believe, a couple of those over a 4-hour period. And then an optional part of the PCA prescription, which generally the pain service needs to give you permission for, is a continuous infusion. So they're getting 0.5 or 1 of morphine an hour on an ongoing basis, so that they, often this helps a lot with sleep to have something on board so you don't have to wake up and push the button. or another basal opioid. If somebody was on a fentanyl patch or OxyContin as an outpatient, they can continue that. So again, the lockout dose, the clinician bolus, plus or minus the continuous infusion. And I think I've made most of these points already, especially if you're on nights. If you're called for somebody who's on a PCA and having inadequate pain control, one of my first questions would be whether they've gotten their boluses, their clinician boluses. Usually nurses will not call you till they've done that, but sometimes they haven't done that yet. And then another thing is, if somebody is on opioids at home and you're writing the primary PCA order set, make sure to add up what they've been getting at home to make sure that what you can give them in the primary service PCA is going to be equal to or more than what they were getting at home. Otherwise, it's going to require a pain service consult. And then there are on the order set a bunch of medications for opioid symptoms, like Benadryl for itching, and some antiemetics. And I personally, unless people are having very severe itching or nausea, I uncheck all of those boxes so that I'm not making people sleepy from anything other than the opioids, and I can really figure out, is it my morphine that's making the person sleepy? Any questions about PCAs? All right. New topic here. So the nurse calls to report that Mr. M, who's a 50-year-old guy, admitted last night for endocarditis, is becoming agitated and complaining of pain, and he's demanding methadone. So you turn to your trusty sign out. He's a watcher. He has a history of opioid use disorder. He has endocarditis. He's on vancomycin and Tylenol. So just a reminder of the signs and symptoms of opioid withdrawal, and that and a little reminder of the time course, that if somebody is using heroin, it should be 36 to 72 hours and withdraw for up to 10 days to 2 weeks. If somebody is using methadone, either on the street or is weaning off their methadone, the peak for the withdrawal would be longer because that's much longer acting. We want to ask folks if they use any other drugs, what their history is of any treatment for opioid use disorder. Have they used methadone? Have they used buprenorphine? Do they wish to enroll in medication-assisted therapy when they leave the hospital? So he doesn't use any other drugs, and he is not on methadone or buprenorphine, and you think that he's in withdrawal. He says that he gets 80 milligrams of methadone in the hospital. You can't verify this. So another question here, what order would you write? Would you give him A, 80 milligrams of methadone? Would you give him B, 20 milligrams of methadone? Would you give him oxycodone as needed for withdrawal? Would you give clonidine, hydroxyzine, and Phenergan for specific withdrawal symptoms and avoid opioids altogether?
Okay, take a couple more seconds to register your vote if you have it. And I'm going to share the results.
All right, so great. Somebody picked every answer, but the majority picked the answer that I would pick, which is methadone 20 milligrams daily. And I'm going to talk about why I think that's the best answer. So big picture, the goals in inpatients with opioid use disorder is to prevent or treat acute opioid withdrawal to allow optimal medical care. This feels silly to say out loud, but I think sometimes we feel like we can cure people's opioid use disorder, that if we don't give people opioids, they're going to do better. If we give people opioids either to treat their withdrawal or to treat their pain, that we could make their opioid use disorder worse. But really, this is a long-standing condition that people have, and what we do in the hospital with the opioids won't necessarily make the opioid use disorder worse or better. Our responsibility is to keep people out of withdrawal so that they can engage with medical care and get their acute problems fixed, and then to ideally also engage with them about longer-term therapy for their opioid use disorder if they're ready for that. We should try to initiate a substance use treatment referral. We should discharge folks with naloxone if they don't have it. There's a wonderful guideline on Occam that's written by Jared Klein from Harborview that I recommend people read as well. So here's the protocol for using methadone for withdrawal in inpatients. The starting dose is 20 milligrams daily. You can give an additional 5 to 10 milligrams within the first 4 hours or so for severe symptoms. You should not give more than 30 milligrams on day 1. You can increase by 5 to 10 milligrams every couple of days for continued withdrawal symptoms. We generally don't give more than 40 milligrams a day in the hospital. Why is that? Because people, if they're in an outpatient methadone maintenance program, they might be on 80 or 100 or 120 milligrams of methadone. The goal is different. The goal of outpatient methadone treatment is to wipe away people's cravings because they're out in the world where they have access to opioids. In the hospital, the goal is really just treatment of their acute withdrawal. And then on top of the 20 to 40 milligrams of methadone, I would use short-acting opioids for acute pain. Questions about use of methadone. You can also, actually I'm gonna talk about buprenorphine in a minute, but I have 2 more slides. So again, my best answer is B, the methadone 20 milligrams. Methadone does have significant drug interactions, so just keep these in mind and make sure you're talking to your pharmacist when you are starting somebody newly on methadone. Rifampin, some of the seizure meds and steroids can decrease the methadone level, and some other antimicrobials and some other agents can increase the methadone level. So I think the take home would be there's a lot of drug interactions with methadone. Your pharmacist is your friend. Buprenorphine is an option for acute withdrawal symptoms in the hospital. You guys, I believe, are going to have that training at some point during your intern year. I use that a little bit less in the acute setting because I'm often treating people's acute pain also, and that's not impossible at all, but a little bit more difficult. It is good to be able to use both methadone and buprenorphine. I'm just choosing to talk about methadone here. All right, just a couple of other quick teaching points. So another patient here, this is Mrs. D. She has new 6 out of 10 suprapubic pain, and her Tylenol and her morphine are not helping. So this unfortunate woman has metastatic breast cancer to the brain and bones. She was admitted for pain control and radiation, and we have been titrating up her morphine for pain. And those are her medications: prednisone for her bony mets, as someone pointed out, morphine, Tylenol, and again, she has 6 out of 10 suprapubic pain, and you go and press on her suprapubic area, and it does indeed hurt. So what do you do next? How do you manage new suprapubic pain in a patient on opioids with advanced cancer? Do you increase her morphine by 25%? Do you increase her morphine by 50%? Do you do a bladder scan, or do you add ibuprofen?
All right, take last answers. And we are almost all on the same page here.
All right. So most folks were concerned, as I would be, that she has urinary retention. So the point here is opioid side effects, and we usually do remember about constipation and nausea, but we forget about urinary retention, also more common in older men with BPH, but certainly possible in men and women of all ages. And we should come running with the bladder scan, consider a Foley catheter. So again, opioid side effects, Foley or straight cath for urinary retention. If you can decrease the opioids, see if you can do that. For men, Flomax often can be helpful. Constipation, nausea can happen with opioids either because of a direct effect causing the nausea, or because people are constipated. So make sure you check that out also. People can get confused from opioids, but make sure not to hang your hat on that because you can miss other important causes of delirium. So sure, it could be the opioids, but think about other reasons why that patient could be delirious. Myoclonus and hyperalgesia are rarer side effects of opioids that you may not see very often, but good to know about. I do see myoclonus with some regularity when patients, again, often on a hemonc service, are on hydromorphone and have renal failure. Sometimes they can get a little bit of myoclonus, and you can opioid rotate them to fentanyl or decrease the dose a little bit. Hyperalgesia syndrome is thankfully rare, but that is at higher doses of opioid. It has a paradoxical effect, and more opioid gives you more pain. And that is a palliative care emergency, and you should call me or whoever's on call for palliative care, and we will help you with down titrating one agent and up titrating another one. So for this patient, we would bladder scan her and see if we can decrease her opioids a little bit. All right. Unfortunately, her saga is not over. 3 days later, the nurse calls to report that she's really hard to wake up. She's breathing about 6. She is full code. You go to see her. You have called your senior resident to come with you, or you're attending if you're on a hospitalist service. Her vital signs are notable for her blood pressure is fine, her breathing is fine, but she's breathing really slow. She's 6 to 8, and she really is pretty hard to wake up. So what do you do next? Are you going to give 0.4 milligrams of Narcan, 0.04 milligrams of naloxone, or are you going to start a drip? And yes, this is kind of a mean question to ask you to keep a dose in your head. In real life, the stat nurse will help you out with this. The senior resident will help you out with this. But it is good to remember in the back of your head, if you can, the dose for this.
I would say this is a good thing to remember. All right, take another 5 seconds. Put your nickel down. Remember, this is how we learn. All right.
All right. So the majority of you answered 0.4, but the best answer in my mind is actually the 0.04, and I'm going to tell you why. So overall, the use of naloxone or Narcan for what I would call like an unintentional opioid overdose in the hospital is usually, well, you may also encounter this people coming into the ER, but if somebody has gotten a little bit too much opioid in the hospital, which really doesn't happen that often, but it's good to know what to do. Don't get overly freaked out just about the respiratory rate. Breathing 8 to 10 in a resting patient is usually okay, especially if the goal is more comfort focus. You don't want to give too much naloxone because it's going to precipitate withdrawal and pain. It's going to make them really, really uncomfortable. So if you do have to give Narcan, the stat nurse will draw up the 0.4 in 10 mLs of saline and give 1 ml, which is 0.04, Q5 minutes. If it's truly emergent or things aren't moving along quicker, I might bump up to about 0.2, but I wouldn't give the whole 0.4. All right. So again, it would be the 0.04 would be your starting dose. One more question here. Back to Mr. G, again, the unfortunate gentleman with metastatic prostate cancer. He's now on comfort care. Remember, he had come in on morphine and he had renal failure and it was building up. So let's say now that he's getting as needed hydromorphone boluses, but he just lost his IV. So the nurse calls you urgently, he's having pain, and they don't have any way to get, he doesn't have an IV right now. He can wake up and maybe he could swallow something, but the nurse is kind of worried about whether he could swallow pills really well. So what would you do next? Would you put in a central line and start a hydromorphone drip? Would you order a PIC, get the PIC nurse there right away, start a fentanyl PCA? Would you put on a fentanyl patch? Or would you start scheduled liquid hydromorphone with as needed for breakthrough?
All right, the votes are rolling in. You can see people are thinking about this one. Take a few more seconds. Commit to something in your head and put it in the poll. All right, here we go.
All right. So my best answer here is actually D. In this acute setting, to start some scheduled liquid hydromorphone with as needed breakthrough. And my intended teaching point was really around liquid opioids, which I think are an underused, wonderful resource for us. So people around the world who are on hospice care don't have morphine drips, right, and PICC lines. They have liquid oral morphine in a solution, which their family member can squirt into their mouth with a syringe. If any of you have kids or remember from your pediatric rotation, squirting Tylenol into a child's mouth, they don't always swallow all of it. Hopefully they don't spit it out, that's not good. But there's some buccal absorption of any liquid medication that you give. And so even if you aren't swallowing any of it, even if you aren't swallowing every last bit of it, you're gonna get the pain control of most of it. And so if you give a 1 milligram per ml solution and you're only using a little bit, it's not an end of life situation. It's just an ml in there or a couple of mls. In the hospice situation, we use a very concentrated solution of 20 milligrams per ml. I have some slides on that. And so again, it's a small amount of liquid in somebody's mouth. So I know that most of you chose a fentanyl patch, or it was kind of a tie between the fentanyl patch and the scheduled liquid hydromorphone. And a fentanyl patch would be a reasonable option for this guy in the future. But if you remember, so a fentanyl patch lasts 72 hours and you don't get much effect from it for the first like 12 to 24 hours. So you would need something in the meantime. So you would come running with the liquid hydromorphone and have him swallow some of that. And then if you had decided with your team that he was a good candidate for a longer acting agent, then a fentanyl patch would be a great option, but it just isn't going to help enough if you stick it on him right now. So again, when people can't swallow, sure, in the hospital people have IVs and we use the IVs, but if your patient has lost their IV or they don't have it right away, liquid medications in general can really be your friend. Morphine and hydromorphone both come in a very concentrated form. And then there's all kinds of other options you can have for the other antiemetics. You can use sublingual ondansetron, you can use rectal options. So don't be too wedded to people having an IV or using an IV for their comfort meds. So again, immediate option for him would be liquid hydromorphone. So just a couple of points on comfort care before we wrap up. There's a great standard order set, so make sure that you use that. And first line really is the liquid oral opioids. Opioids are first line treatment for both pain and dyspnea. If somebody has an IV, it's okay to use an IV PRN breakthrough. If people have refractory pain and have the IV, and especially if they're going to be staying in the hospital, you can transition to a morphine drip using the standard order set. Benzodiazepines are also helpful. They are second line for pain and dyspnea, certainly more like first line for anxiety and insomnia. So again, comfort care order set, look for that. One really picky point here, because this has come up, it's like really difficult for some reason to figure out how to order liquid morphine. The standard dose in the comfort care order set is the concentrated solution. So if you want that for some reason and you're not using the comfort care order set, you just pick morphine and then you go to the part that gives you the format, and you can scroll through and it'll give you pills and IV, and the concentrated solution is Kant's solution. There's also 1 milligram per ml, which I would use more often for an opioid naive person. I just prescribed it this week for a 93-year-old guy who needed 2 milligrams of oral morphine, a really, really small dose. and that's the oral solution. This is something that you do not need to remember and that you can always ask your pharmacist or your senior resident. All right, I've come to the end. Thank you for bearing with me. I know I threw a fair amount of information at you. I'm happy to answer questions now. I'm happy to answer questions by email. There are a lot of people who can help you take care of patients with pain, your senior resident, your pharmacist, the pain service, the palliative care service. Don't try to go it alone with pain management or really with anything. There are no badges for independence, bravery, and courage. There should be badges for teamwork and excellent care of patients in the hospital, especially those with pain. All right.
Thank you so much, Susan. Why don't I give a few minutes if anybody has questions. I know Susan has just a couple of minutes before she heads down to Harborview for the day. And I don't see anybody unmuting, so I'll continue to monitor the chat. I just want to thank Susan for wrapping us up for this year's ITC. I want to thank you all for Zooming in and joining us in this new format. I really appreciate all of your engagement and attention. I know that many folks are hoping for the recordings of our lectures, as am I. I think the residency has identified a way to house all of these very, very, very large files, and I'm working on uploading those today, so I will make sure to get that link out to folks. We will come back together next week, not at 7 a.m., but Ken will be sending out an email soon with a schedule for next Thursday's intern didactics in the morning before your retreat in the afternoon. I believe we'll start at 8:30 or so, and we're going to bring in one last ITC lecture starting at 9. That's Ken's talk on an approach to dyspnea. And we're doing that because we squeezed in the COVID talk earlier this year. So with that, again, thank you. I will send out I'm going to post the QR code here for evaluations, and I'll post the QR code for evaluations, and we'll send it out since I know folks are needing to get back to rotations, and we'll wait here if there are any other last questions or thoughts.
All right.
Thank you so much, Susan.
See everybody around. Have a great day.
Thanks, Susan. Talk to you soon. All right, is there anybody still on who needs the QR code? I'm going to go ahead and stop the meeting. Okay. Take care. Bye-bye.